Anorexia nervosa, bulimia nervosa, and BED are the three types that we're going to talk about as far as eating disorders. Anorexia nervosa has increased over the past 30 years in the United States as well as in Western Europe. Anorexia nervosa is a psychiatric illness that describes an eating disorder that is characterized by an extreme low body weight and a body image distortion with an obsessive fear of gaining weight. They're constantly afraid of gaining weight, but yet they're severely underweight. In this individual, their psychosexual development is delayed. They experience feelings of depression and anxiety almost daily. In your mental health book, it's chapter 32. There is the diagnostic criteria for anorexia nervosa as well as for bulimia nervosa. While anorexia nervosa primarily affects adolescent females between the ages of 12 and 30, approximately 10% of people with anorexia are also diagnosed as males. Individuals with anorexia are known to control their body weight commonly through means of voluntary starvation, purging, which means excessive amounts of food taken in and then immediate vomiting following, excessive exercise, or other weight control measures such as abuse of diet pills or other prescription diuretic drugs. They have a refusal to maintain a body weight that is above minimal or even normal weight for age and height. In females, there is an absence of 3 menstrual periods. Their inability to eat is not due to a lack of appetite, but the strong repression consciously of hunger. And that is their need to be in control. Usually this individual is an overachiever, sometimes described as a perfectionist. They would be looked upon as the model child by others. The parents may also be very high achievers. They have very superficial relationships, though. They don't connect with other people. They're not socially apt. They have extreme and marked constipation, hypotension, bradycardia, hypothermia, dry, thinning hair, and also lanugo. Now, lanugo in grown humans is a possible sign, should be a red flag for you as a sign of starvation. As the body attempts to insulate itself when the body fat is lost from the extreme low body weight, the body will begin to cover itself with the dry, thinning lanugo, the white, furry hair that a lot of babies are born with. But it is not normal in an adult. Also, these patients will experience anemia, hypoglycemia, hypokalemia, any or all of which could be severe enough to lead to arrhythmias and or heart failure. Drug treatments such as your SSRIs have not been found to be generally effective for either treating anorexia or for preventing the relapse. Although it has been noted that there is a lack of adequate research in this area for prescribing SSRIs related to anorexia. It is common, however, for antidepressants to be prescribed in your patients with anorexia, often with the intent of trying to treat the associated anxiety, depression, guilt that is associated with this diagnosis. Supplementation with 14 milligrams a day of zinc is recommended as a routine treatment for anorexia nervosa due to a study showing a doubling of weight regain after treatment with zinc was begun. Zinc is hypothesized to be an increased effectiveness of neurotransmission in various parts of the brain. There are no medications indicated specifically to an eating disorder. Meds have been given, as I said, to treat the symptoms of depression or anxiety that might accompany this disorder, therefore hopefully resulting in a more stable weight as the outcome. Some medications have weight gain as a side effect, and these medications have sometimes been used because of their side effect of weight gain, in addition to some appetite stimulants being given as well. Now, bulimia nervosa is the most common symptom of purging. The most common form of bulimia nervosa is purging. However, it can also have symptoms of fasting, abuse of laxatives, enemas, diuretics. Also, the over-exercising. This is also common, all of which lead to dehydration and electrolyte issues. From the purging and the constant throwing up and the stomach acid, you'll see their teeth being eroded. Also, they can tear or rupture the gastric or esophageal mucosal lining from the repeated vomiting. These patients generally have a hoarseness about their tone of voice. They have a general sore throat. Bulimic episodes may also be part of anorexia nervosa. Usually you will see bulimia in your older females than you do with anorexia. You'll need to get an assessment if there is a history of 20 to 30 pounds gain or loss in weight. This is a key issue. The patient does not usually appear emaciated. They might be about a normal weight in appearance, possibly slightly underweight or maybe slightly overweight, but their weight fluctuations are the results of their alternating binges and fasting. And the binges, of course, are followed by the purging. The frequency and severity of the binging will vary. It can be occurring 2 to 3 times a week, or it might be occurring daily or more than once a day. For these individuals, when they go on a binge, it is not uncommon for them to ingest 10 to 20,000 calories of food. The food that they consume is in itself very high in calorie, usually very sweet and has a smooth texture so that it can be eaten rapidly. Sometimes their food of choice can be eaten so rapidly they don't have to chew it. They may also accompany this binging with alcohol to decrease the abdominal pain. And this is generally considered what we call a secretive syndrome. They don't want other people to know that they're binging and purging or that they're overeating and fasting. They may steal money from their loved ones. They may steal food or laxatives. And they're always going to be binging and purging in private. Binge eating disorder, or BED, is not classified as a psychiatric disorder because of strong emotional factors that are associated with the condition. However, there is a third class of eating disorder that is being considered, and that is binge eating disorder. Obesity is a huge factor in binge eating disorder. These clients will, again, binge on large amounts of food, but they do nothing to rid their body of these excess calories. So there's your difference from bulimia binging and BED. They have a particularly high triglyceride and cholesterol levels. They have trauma to their weight-bearing joints, an increased workload on the heart and lungs. Meridia was approved by the FDA in 1998 for the treatment of obesity. It acts by inhibiting serotonin and norepinephrine. The severe side effects of Meridia, however, include hypertension on a patient who already has an increased workload of the heart, tachycardia, and seizures. Impulse control disorders. Impulse control disorders sometimes when this individual follows the impulsive act through with the behavior, they may then experience regret, or there may be no regret or guilt with an impulse control disorder. It is imperative to note that it is the failure to resist an impulse or a temptation. They must perform this act. Sometimes this act is going to be harmful to themselves or harmful to others. But as they debate whether or not to follow through with the behavior, they have such an increasing sense of tension or arousal before they actually commit the act that once they've committed the act, they experience pleasure, gratification, relief at the time of committing the act from the increasing anxiety and tension. Individuals with impulse control disorder follow their impulses to behave in a certain way, usually without regard to the consequences of their behavior. Seldom are professionals able to pinpoint why the individual acts in the way that they do, and almost never can the individual pinpoint why they do what they do or why they find these acts pleasurable. Many of these behaviors have very adverse or even harmful consequences to the individual themselves. The individuals function fairly well in other areas of their life. It is just when the tension begins to build over a certain act or committing this act, they become unable to contain their behaviors, and it is the instant gratification of following through with the act that prevails. There are 5 categories of impulse control disorder. The impulse control disorders are intermittent explosive disorder, kleptomania, pathological gambling, pyromania, and trichotillomania. The onset of these disorders usually occurs between the ages of 7 and 15. Intermittent explosive disorder is also layman's term hot-headedness. Kleptomania is stealing. Pathological gambling speaks for itself. Pyromania is fire starting or fire setting. Trichotillomania is pulling one's own hair out. Also, there's one that's not on the slide that is called dermatillomania, and this is skin picking over scabs or wounds. The impulsivity is the key feature of these disorders. It can be thought of as seeking a small, short-term gain at the expense of a large, long-term problem. Obsessive-compulsive disorders most commonly are characterized by these intrusive, repetitive thoughts that result in compulsive behaviors and mental acts that the person feels driven to perform. However, these behaviors or these mental acts are not connected to the consequences of the behaviors. The essence of emotional self-regulation is the ability to delay impulses. So for your impulse control disorders, these individuals do not possess emotional self-regulation. They are unable to delay their impulses. It is that instant gratification from committing the act or the behavior that takes over. Interventions and treatment. Individual psychotherapy with impulse control disorder or with intermittent explosive disorder has not been proven to be very successful. Group therapy may be more therapeutic, and family therapy has been a successful form of treatment for adolescents or even young adults. Mood stabilizers such as lithium, lithobid, escalith, anticonvulsants such as your valproic acid, VPA, which is Depakote, SSRIs, anti-anxiety classification of medications such as buspirone and Buspar, beta blockers, antihypertensives such as propranolol or Inderol. Antipsychotics were used more in the past, but became very controversial related to the adverse side effects that antipsychotics have. Now some of the newer atypical antipsychotics may be more acceptable in use for treatment because that, their side effects are sometimes viewed as less dangerous than the typicals. You may see these patients on your pediatric units, or you may encounter these patients in the emergency department. Parents may be in a parallel group for enhancing their parenting skills. We can also encourage them to get into some type of community support, talk with other parents who are also dealing with the same issues so that they don't feel so out of control and so isolated and so alone. Because again, remember, these disorders usually have a typical onset that occurs between the ages of 7 and 15. Personality. Personality is described as enduring patterns of perceiving, relating to, and thinking about the environment and oneself that is exhibited in a wide range of our social and our personal contexts. Now, would you agree that this requires flexibility in our ability to perceive, relate to, and think about our different environments? Certainly. Are we capable of adapting, changing our responses and our reactions when we're placed in different social settings compared to private settings? Absolutely. So, with that said, for a personality disorder to occur, it's going to be when these traits are inflexible, maladaptive, and cause significant functional impairment or subjective distress. What does subjective distress mean? The impairment or distress to the individual as stated by the individual. Whatever they tell you is the level of impairment that is being caused, well, that's what the distress is being caused. However they perceive it. This becomes tricky because the fact that most people with a personality disorder do not perceive themselves as having any problems. So, for a personality disorder, there has to be disturbances in 2 or more of the following areas: cognition, affectivity, interpersonal functioning, or impulse control. Has to be disturbances in 2 or more of those 4 areas. Personality disorders are classed according to specific criteria, and they're going to go into one of 3 clusters. Cluster A, B, or C. Then they're going to be further subclassified into specific disorders. The common characteristics for each cluster, A, B, or C, of a personality disorder is going to be, for your cluster A, personality disorders, they're characterized by odd, eccentric behaviors, usually paranoid, schizoid, and schizotypal personality disorders are falling under cluster A. Your cluster B personality disorders are characterized by a dramatic, emotional, erratic type of behaviors. These are your antisocial, borderline, histrionic, and narcissistic personality disorders. Cluster C personality disorders are characterized by anxious and fearful behaviors. These subclasses are avoidant, dependent, obsessive compulsive, and passive aggressive. Beginning with cluster A personality disorders, we'll start with our paranoid personality disorder. Characteristics are a suspicious and mistrustful nature of others. This individual is on guard all the time, very tense. They are humorless, usually display a blunted affect. Your paranoid personality disorder is a pervasive and long-standing suspiciousness, generalized mistrust of others and what their motives are, always feeling like, other people are out to get me or to take advantage of me. So your paranoid personality disorder will avoid interactions with others. They're overly sensitive and they misinterpret others' actions or they misperceive their environment, constantly putting others to the test simply because they do not trust them. Even if they pass one test, there's another test. There's no acceptance of behavior. They place their own responsibilities on others. It is their fault that this happened to me. I wouldn't be here if they hadn't, that kind of thing. They usually display envious or hostile behaviors toward people that they see as successful. They're very volatile, easy to anger. They have a loss of control for very brief periods, but then what does that do? That makes us vulnerable when we're not in control. So your paranoid personality disorder, they may lose control for brief periods of time, but they will regain their composure and their control quickly. Why? Why does someone have a paranoid personality disorder? The hypothesis on that is parental antagonism and harassment. It begins in early adulthood and it can be displayed in various levels. The behaviors are long-standing. Paranoid people don't trust enough to ask for help or treatment. So you're not going to see a paranoid personality disorder come in for treatment on their own. If they are convinced into treatment at the request of others, they can often present themselves in a way that they do not even appear to be maladaptive at all. Yet, if you spend a little time with them, you'll quickly see that they are insensitive to others' feelings. They are ready for any real or perceived threat. Paranoid personality disorder is more common among men. Focusing on the hypothesis of parental antagonism and harassment, It is thought that this individual may have been the focus of displaced parental anger as a child, thereby growing up. Their hope for affection and approval was never met, so they stopped desiring affection and approval. They learned instead to anticipate rejection, humiliation, and betrayal by their caregiver, who is supposed to love and protect them and be most important to them. So, a paranoid personality disorder's mantra is to attack before attacked. The schizoid personality disorder, they choose to be alone, kind of like a hermit. They don't desire any intrapersonal relationships. They don't miss them. They don't feel regret or remorse because they don't have that involvement. They're cold, indifferent, and unsociable. In a social setting, however, this cold indifference appears to be shy or anxious. They appear out of place. They're usually very serious. They don't have that spontaneity, and their affect is quite bland. Your schizoid personality disorder is characterized by a lack of ability to form personal relationships or to respond to others in any meaningful emotional way. The lack of interest in social relationships tends to project them into a solitary lifestyle, a lifestyle of secretiveness and emotional coldness. They're unable to experience pleasure in life, but they are capable of overachievement in their intellectual pursuits. The schizoid personality disorders are usually seen as your researchers who have doctorates or higher. They live in these very remote settings. They do a lot of research with nature, weather, animals, but they don't desire or have a desire for any human contact. Again, the schizoid personality disorder individual is not going to seek out treatment and generally does not have a significant other to interest them in finding treatment. There is no one in their life that's going to compel them into treatment, so we don't commonly see schizoid personality disorders in clinical settings. The diagnosis is seen more frequently in men, but we really don't know the true male to female ratio since the treatment of it is very sparse. So why? Why does someone become a schizoid personality disorder? Meaningless, neglectful childhood. Again, we're back to the childhood. It is hypothesized that extremely introverted people seem to have a hereditary link to children who are also notably introverted. So they learn their behaviors. It doesn't mean every shy, quiet, unsure person will have a high risk as a child who develops a schizoid personality disorder. They find social settings very unpleasant as a child. They were placed in unpleasant social settings repeatedly as a child that might have left the child feeling cold, without a positive meaning. A childhood experience without love or hugs or nurturing. They grew up feeling no parental empathy, and there was none demonstrated for them that they could relate to or draw experience from. So this child grows up thinking that relationships are not valuable, they're not worth pursuing, and they are a waste of time. This type of childhood possibly contributes to an adult who is also very temperamental, shy, anxious, and yes, introverted as an adult. Schizotypal. Your schizotypal personality disorder is characterized by a need for social isolation. Their difficulty is in with thinking, perceiving, and relating to others. It is a little bit similar to schizophrenia, but less severe. They have a more maladaptive personality than schizoid does, though. They isolate, they're apathetic, they believe that they possess magical thinking, their ideas of reference are a little bit off. They have illusions, bizarre, illogical, tangential speech. Their affect is usually displayed as a bland or inappropriate to the current situation. They have odd behaviors, odd ways of thinking and perceiving. They often will experience unconventional beliefs, superstitions. They may believe that they have a sixth sense that other people do not possess. They may describe themselves as being clairvoyant. Oftentimes they describe themselves as being able to see that other people can feel their feelings. They believe that they are that transparent, that other people can tap into their feelings or their thoughts. They're overly sensitive to the behaviors of others and feel that they are different. They know that they do not fit in. So they have fantasies about real relationships, and they substitute these made-up fantasies or these delusional thoughts for real relationships. Increased stress is going to cause decompensation. Brief periods of psychosis appear. When this happens, they're in their own little world. They may gesture to themselves, talk to themselves. Why does someone develop a schizotypal personality disorder? Well, there's a possible link to a first-degree biological relative that has schizophrenia, and there are early affective deficits. Early on, this individual is uncomfortable with personal affection, personal touch, closeness. It is likely that they were overlooked or even rejected and humiliated by others when they were very young. Most likely their primary caregivers, which then instilled in them a low self-esteem, an inability to trust. So they begin to withdraw into their own little world, which provides them with rewarding existence. When you get to create your own little world, you get to be the mayor of the town. Low doses of antipsychotic drugs may decrease the severity of these symptoms that are exhibited in the transient psychotic states in relation to their thinking, their perception, or their anxiety. Use clear and simple explanations and instructions. This patient cannot tolerate group therapies, so do not expect them to be involved in confrontation or much emotional involvement at all. You can only be supportive and help this patient to become as involved in the therapeutic milieu as they possibly can benefit from.